Welcome to Realizing Resilience, a podcast from the Connecticut Women's Consortium. We're not behavioral health professionals, but we're your gateway to real conversations with the experts. Each episode, we'll delve into the vast landscape of mental health, from personal stories to expert insights. Together, we'll bridge the gap between clinical expertise and personal experiences, connecting with diverse voices and perspectives. Join us for insightful conversations that demystify the world of mental health.
Dr. Peter Tolisano is a board-certified clinical psychologist. He has been the statewide director of psychological services at the Office of the Deputy Commissioner for Connecticut Developmental Services since 2013. His various responsibilities include overseeing the mental health and behavioral needs of individuals served by his agency. He interfaces with national entities and other state agencies, including DCF, DMIS, SDE, DSS, and OCA in his consultations, which often relate to positive behavioral supports. Dr. Tolisano also maintains a private practice in the Greater Hartford area that focuses on the provision of psychodynamic psychotherapy and EMDR for trauma recovery. Welcome back to Realizing Resilience. My name is Alana.
And I'm Marisa.
And today we have the pleasure of speaking with Dr. Peter Tolisano. So thank you so much for joining us.
My pleasure to join you guys. Thank you so much for having me.
So for people who might not be familiar with the term psychopharmacology, what is it and how has the field grown or changed over the years?
Sure, I'm happy to speak to that question. So psychotropic medications, and the term is synonymous with psychiatric medications, are drugs, and drugs being the umbrella term, that are used to treat mental illnesses. And the definition of psychotropic medications dates back to 1956, actually. They're medications that are capable of affecting mental status, perceptions, emotions, behaviors. We look at the derivatives of the term psycho meaning mind from Greek, and tropos meaning to turn. So the term hence means to turn the mind. Now, a more contemporary definition would be to nourish the mind. I can even speak a bit to the historical context of how we kind of got to this point as well. In the 1950s, there was a psychiatrist out of New York, I believe, named Donald Klein, and he died a year or two before the pandemic. And he had a pretty rigorous background in biology, and he started to look at how psychiatric problems might have a biological basis and could be treated with medications. And that kind of started the field of psychopharmacology. The first psychotropics, interestingly, when I present on it, I share with folks, were Librium and Valium. And a lot of times people don't realize that the names of the medications denote either the side of the molecular formula that the medication is based on, or what they're trying to do with it. So Librium and Valium actually tied to the word equilibrium, or restoring equilibrium. And then also, as we kind of think about the evolution of psychotropics, really there was a watershed in terms of the mental health treatment, because it led to the deinstitutionalization movement. So Haldol, Thorazine, Prolixin, those are really revolutionary. Obviously, significant side effects oftentimes with those medications, but they allowed people to move back into communities. So that was really, again, a turning point in the field of mental health care. And if we think about psychotropics nowadays, so about 20% of adults in the United States receive mental health treatment. And of that 20%, Alana, about 80% get medications. So medications are clearly part of comprehensive treatment in concert with other things, namely psychotherapy. Oftentimes, medications in this day and age are indicated for more moderate to severe conditions rather than mild ones. And in closing, we have probably 5 areas of psychotropics we can think about. So there's antidepressants, anxiolytics, which are anti-anxiety medications, stimulants or psychostimulants used for things like attention deficit disorder, and also sometimes sleep disruption, antipsychotic medications, and then lastly, mood stabilizers.
I never considered where names of medications really even come from. I always just assume it's just people need to have minds that are way beyond my own to even conceptualize what you could even name a medication. But knowing the root of something that seems so unreachable and have it be so simple and so easy to understand is actually really
Yeah.
nice.
Thank you so much for saying that. Yeah, so in my presentation, one of the things that I share with folks is this. So Louis Pasteur actually discovered that medications have a left and right side of the molecular structure. And if you get a medication from your pharmacy, right, it has the pamphlet in it, it has the organic compound, right? And you notice that there's a lot of symbols in that schematic and so forth. Well, The right side of a medication actually tends to produce the negative side effects because it affects other areas that we are intendedly impacting. The left side is the one actually that produces the effects that we're looking for. So a really good example of that is Celexa versus Lexapro, which are very, very common antidepressants, right? So Celexa is both the left and right sides of the molecular structure. Lexapro is the purified version, and it is the left side of the molecular structure, hence the prefix LE in Lexapro. So there's a reason for it.
A method to the madness.
Correct.
I was gonna say a rhyme and a reason. Yeah. Yeah, you had mentioned that like in your trainings you kind of break these things down. And so in your training that's coming up, psychopharmacology, the basics and beyond, you focus in part on treating individuals with developmental disabilities and also the elderly. So why is it important, especially with these specific groups, to approach medication differently?
A number of different reasons. I would say the core reason for me is that they're very vulnerable populations. At the same time, they're very heterogeneous groups with a lot of variation there. Certainly, my work with the state is in neurodiversity, and that's an area that has gained a lot of interest, rightly so. So when we're talking about neurodiversity, we're talking about an umbrella term encompassing things like autism spectrum, ADHD, learning disability. And again, this is a population of folks, and also the elderly, that have kind of fragile and complex neurological profiles. So very important, I think, to try to protect those individuals as much as we can. A lot of times we have caretakers and staff that are advocating for people when they go to receive medication. So to try to educate people on those areas is something we can have really good impact with. I think also one of the reasons why I focus on those groups, the elderly and folks with developmental disabilities, is that they tend to have a lot of concomitant or accompanying conditions with those particular diagnoses. So again, they be very complex profiles, and it's important to understand how meds may or may not impact those particular populations. That being said, oftentimes when people have challenges, whether in mental health or behaviors, especially with developmental disabilities, we're oftentimes looking at medications as providing a stable neurological base on which to do other forms of support. So the meds become really, really crucial here in understanding how we can benefit those special groups. With regard to the elderly, it's a very poorly researched group. Part of that is because, again, they have a lot of confounds from medical illnesses, and folks don't often look at that. With the elderly, there's something called the Beers criteria, which are areas of inappropriate prescribing for the elderly. But again, understanding that group and how health conditions affect them is really important. Something I mentioned in the presentations is that every year after midlife, say 30 to 35, we lose about 0.75% of our liver and kidney functioning. So lower doses are more important for elderly than folks who are younger. So again, a lot of nuances in that.
I didn't even think about that in terms of dosage. Like I was thinking with the elderly, it makes sense to think about compounding factors, but that's interesting and I think a thing that people should probably be considering more frequently.
Yeah, for sure, for sure. Actually, there's a piece in the New York Times recently about how, individuals who, for example, may have lifestyles where they engage in behaviors that could be hurtful to their health. And the marker actually of that in lab work, and I've had this happen with individuals that I've worked with, is around 35 or 36. You can start to see shifts in, metabolization of blood sugar and things like that. And it really corresponds to also to that change in how the liver and kidneys work as we age.
So stop drinking at 34.
Get ahead of the curve.
Yeah.
And even too, as you get older, you've been taking medications for maybe longer periods of time. You've been on this medication since you were 40. You've been on this medication since you were, 25, whatever. And I'm sure that prolonged taking of certain medications or maybe improper use of medications or whatever can also take a toll on your body. That by the time you're older, there's different shifts that may have to be made.
Oh, for sure, sure. Yeah. You see a lot of prescribing that is inherited from one prescriber to the next, and people are on medications for an extended period of time. One of the things I encourage people to do is to just go back, especially when folks are on multiple medications, to revisit the original rationale of the prescribing. And I can't tell you how many times I've been really astonished to see how folks don't recall what that rationale is, or the rationale no longer applies.
Yeah, they've been taking them for so long that it's just part of the routine. I take these 3 in the morning, I take this at night, and I just take it
Exactly.
because it's been in my pillbox.
Exactly. Yeah. I actually had that happen years ago. I was on a work group and a pharmacist actually had a family member, and we were talking about that technique of going back and revisiting the rationale. And this family member was on multiple medications, I want to say north of 10 or 12. And they went back and they found that I think it was 5 or 6, a good percentage. There's no rationale for the meds that this individual was prescribed or were no longer effective.
So you're also going to talk about reducing polypharmacy. That's a tongue twister. I think I can kind of get the gist from context clues, but can you explain what that is and why it matters, why it's an issue in behavioral health settings?
Polypharmacy is an area that within my department we've focused a lot on. So just to give folks an understanding, so polypharmacy again comes from Greek, poly meaning more than one, and pharmakon meaning drug. It's technically defined as the simultaneous use of multiple medications to treat a single condition or a single person. So in its more conventional definition would be prescribing more than one drug, but there's really no standard definition to a cutoff point with regard to number. We do know if we look at the CDC latest statistics, 1 in 5 adults in this country between the ages of like 40 and 80 take 5 or more medications. We know that in the realm of intellectual developmental disabilities, about 20% of those individuals are exposed to polypharmacy. The threshold that I tend to think of when we're talking about psychotropics is 5 or more. In my department, the policy that we've developed and has been quite effective has been the number 3 based on the average that we had back in 2018. We incentivize prescribers to lower that number. The most common psychiatric or psychotropic medications that are exposed to polypharmacy are antipsychotics, followed by ADHD meds, and then antidepressants. And then we could certainly get into definitions, more so about what polypharmacy is. Oftentimes, when I think about it, is I'm looking to recommend reduction in the redundancy or duplication of medications, right? More meds that are necessary, but also it could be meds looked at as meds that are not effective. And then there's different types of polypharmacy as well. We have polypharmacy in the same class, we have polypharmacy across classes. Sometimes we have what's called augmentative polypharm, where we use one medication to benefit another. The other one I think about is something called total polypharm, or like pill burden, right? We know like elderly folks who are taking, 15 medications, right? It's an excessive amount that causes a huge amount of effort needed to manage that, and also a lot of money as well. There are certainly scenarios where polypharm is acceptable. For example, treating, 2 distinct phases of an illness. For example, someone is diagnosed with bipolar disorder, they have a manic phase and a depressive phase, may require 2 meds. For example, if somebody has an illness that is very resistant to treatment, we need more medications. But the main thing with polypharmacy are that we're concerned about are the negative effects on the individual and also on the system. And what I mean by that is, so on the individual, has a significant risk of what's called a cascading set of side effects, right? The more meds we put on, the more chances there are they're going to have drug interactions. We also see in the system issues around like diagnostic inflation, right? People have more meds, so they need more diagnoses to justify the meds, and obviously the high cost on the system. But one of the things I also note in the presentation is that, when people are taking too many medications, the thing that the literature does support is that they will have a poor quality of life in several areas. One is memory decline, right? Especially for people predisposed to cognitive impairment, and then also falls due to balance problems and muscle weakness from a lot of medications. And as you guys pointed out, many people are not taken off medications they've been prescribed for years, even though they may no longer need them or there are better formulations out there.
I think societally, we kind of have gotten to a place where we just accept that at a certain age, you're going to be taking a bunch of medications. And it's become so normal. There's a lot of people who see their grandmas, their grandpas, they have these massive lists and all
Yeah,
this stuff. And it's just become this normal thought
exactly.
that you don't even consider, do I have to be taking all of these at the same time
Mhm,
forever? Obviously, there's
exactly.
certain ones you need to, but you just accept, well, I guess I'll just take this until I die, and that's not always the case.
Exactly. Exactly. It's so important to come back and question, right, in a healthy way and find providers who are willing to have that conversation.
I think too, one of the things, at least like for me and in experiences that I've heard about anecdotally with psychotropic medication, there's that fear that you're gonna have like a crazy withdrawal, or when you come off of it, you're gonna be uncontrollable in some way too, where it seems like people are kind of afraid of who they'll be without it.
Sure, sure. Yeah, the tapering people off medications, the analogy I use is like landing an airplane. You want to do it very gradually, but there's other things that we can't anticipate. Like, for example, antidepressant medications with short half-life are very prone to that serotonin discontinuation syndrome. So it can be expected in some cases. There are techniques that we can use to add in longer half-life medications when somebody's tapering off. So again, these are not things that sometimes providers are aware of. But yes, there's a lot of hesitancy around that, Alana. But there are techniques that we can use to prevent or mitigate the withdrawal from meds. Sure.
Going back towards psychopharmacology, are there any recent developments or emerging trends within this scope that you think are especially promising or worth watching?
Yes, thank you. Good question, Marissa. So the area of what's called precision psychiatry has come into the forefront in the last decade or so. So this is focused on genetics and biomarkers to tailor meds for better efficacy and reducing the side effects. Something that's been out for a good decade that I am a huge proponent of. And there's a lot of hype versus hope with this, but I have had a number of cases, if you will, where this is played out is genetic enzyme testing. It's based on a saliva swab. I've written it into policy in the agency that I work with, and in my administration and commissioner and so forth have been super supportive of it. And what the enzyme testing allows us to do, it doesn't tell us what's effective with the medications, but it narrows the parameters of the prescribing. And I've had a number of instances, both in state service and private practice, where individuals have done a lot of trial and error, and it's taken an excessive amount of time that we could have determined the same thing with genetic enzyme testing. For folks who are not aware, if metabolism, right, based on liver enzymes largely, is reduced, then we get a higher blood level of a medication and negative side effects. If metabolization is too rapid, then we get a lower blood level of the medication and there's no therapeutic benefit. And there's a lot of factors. Again, we want to really be thinking about the characteristics of each individual based on age, race, ethnicity, physical condition. And really, again, genetic enzyme testing can reduce frustration, the time consumption, the financial expense, even the debilitation that comes from not being on the right meds. And the system is thankfully picked up on that. So, for example, with Medicare and Medicaid, there's no cost to do the genetic enzyme testing. For most commercial insurances, out of pocket, it's about $330, which again can save us a considerable amount of time. And I find it that the enzyme testing is great in complex cases. But at the very least, it's good for helping prescribers to adjust dosing, especially when they don't have lab values for medication. So that's one area again that I think it has come on the scene to help folks. But there are other areas as well, and I'm happy to speak to those in terms of future trends. So I think the area of improved drug release, so controlled release with less fluctuation around things like ADHD meds, is really something I think will help folks a lot. Targeted delivery of meds to specific brain regions, the use of prodrugs, where drugs don't start to metabolize until they hit a certain part of the GI system, is a trend that we've seen recently. I know a lot of folks have been interested in emerging trends around like ketamine derivatives and so forth, and they can be effective in a number of ways. Unfortunately, the benefits tend to be short-lived, but the faster acting medications and things that could be used a short amount of time are really helpful. For example, I have a lady that I work with in private practice, and she recently went through about a postpartum depression. We wound up doing a lot psychotherapeutically to support her and had an existing prescription for Zoloft, which helped to a degree. But then she had this exacerbation in postpartum symptoms, and she went back to her OB and got a medication that's been out for, I want to say maybe 3 years or so, called zuranolone. So it's taken 3 days from the onset of symptoms. You take it for 2 weeks and then you discontinue it. So it's, again, faster acting for a shorter amount of time. On a different note, I think there's other areas that the field of psychopharmacology is going to be looking at: the role of inflammation, especially the role of cortisol. We know that cortisol breaks down the effectiveness of medications. That inflammation hurts the body a lot in many ways. So that's important, focusing on earlier stages of diseases, and also the whole notion, and a very different note, of elective or enhancement psychopharmacology, where people want to bolster their performance. It's a slippery slope because we've seen things like academic doping and things like that, but the enhancement psychopharm may be an area we also see as well. You may even see some of the medications going over the counter, typical SSRIs. The pharmaceutical companies don't profit a lot on those, so they may relinquish some of the control over those. You may see those go over the counter.
That's really interesting. Also, the genetic enzyme testing sounds amazing and super promising. I didn't know that was an option. And one of my close friends has been in that boat of they just kind of throw meds at her and see what sticks. And it's been really torturous, I think, for both her and her team, where something seems like maybe it's working for a little and then it's not. So that's really optimistic that it will take some of the guesswork out of that process.
Yeah, for sure. I've had instances, sadly, where, especially in private practice, where people come to me, obviously for a variety of things, but medication consult may be one area. And I've had instances where people have been trialed for years on certain types of medications, and we do the enzyme testing, and lo and behold, they don't even have the enzyme to metabolize meds in that realm. The one that I use as an example in my current presentation, a 16-year-old, been working with her practice for about a year and a half, and she was hospitalized due to depression with significant suicidal ideation, very difficult metabolic profile, and did the enzyme testing a number of months after it started. And lo and behold, all the meds she was trialed on were listed as ones she could not metabolize. And again, having had that list in hand, we could have saved a lot of time wasted on trial and error, to your point, Alana.
Well, it's exciting to hear about so many developments because I feel like too this is a field where people do sort of see it as being stagnant, where it's like
Yeah,
we only have, there's Prozac and there's lithium and that's it. So
yeah.
it's exciting that there's so many new things on the forefront.
Yeah, for sure, for sure. Yeah, the enzyme testing actually comes from the world of oncology. A lot of cancer treatments nowadays are based on genetics. And again, the one reason I say to people, the proponent of it, is the cost, relatively speaking, for 300 some odd dollars and a saliva swab. You get the results in a week, and it can really inform the work that we're doing.
I appreciate you taking the time to speak with us today. This was so informational. I really enjoy it. I love when people come on here and you can tell that they're so clearly passionate about what they do, that even with a short interview, I get to walk away with so much knowledge and I get to enjoy a conversation. So I really appreciate you taking the time.
Oh, thank you so much, Marissa. Thank you, Alana. Thank you for the kind words, and I really appreciate the support of the efforts that I'm putting into this, and it certainly nourishes my efforts, if you will, on doing the work.
Links will be in the description to sign up for Psychopharmacology, The Basics and Beyond Part 1 and 2 on July 14th and July 21st. Please note this is a two-part series and both sessions must be attended to receive credit. Check out our links below to keep up with us at the Connecticut Women's Consortium. Thank you for tuning in today, and we'll see you next time.